This is one of the sessions that everybody always gives us a high review on, and that's the update on research. And we've got a great guy today, Ted Burns, who is the head of our Medical Scientific Advisory Board. He's served 2 years in that capacity and will be becoming an old man like me. He'll phase off in the fall to be replaced by another old man, Bob Ruff, over there. But Ted, you can read his bio. I'm not going to read it to you. All I can tell you is Ted is a great guy, a great friend of mine, and a great friend of the myasthenia community. And he is tireless. He has helped to change the face of the MSAB, to re-energize it and to refocus it. And that is to all of your benefits. So Ted, it's all yours.
Thanks, Sam. I may be an old guy. I'm not as old as Bob Ruff, though. I just want to start by saying it's been an honor to be chair of the MSAB, the Medical Scientific Advisory Board, the past year and a half, and I am rotating off in October, and Bob will come on, and Bob's an amazing guy. It'll be definitely an upgrade, but I think we've made quite a bit of progress here. When I assumed the position 2 years ago, I was going through, some of you know this, I was going through cancer treatment, and one of the first things I did was call Sam and say, I really want to do this. This is important to me. And he said, hell yes, you're going to do it. We want you to do it. We need you to do it. I wanted to do it. I needed to do it. And it's just been a privilege to do this. I gave a similar talk, different, but similar talk last year at the Philadelphia meeting. And there was a lot going on then, but it's stunning to me how much is going on right now in terms of research in the myasthenia world. And we'll try to cover a fair amount of it. Some of it may be duplication. I know you guys know a lot of this, and I know Mike Hare gave his MG 101 talk this morning, but I just want to make sure we're all on the same page. I think you all know myasthenia is an autoimmune disorder. Your immune system is attacking the neuromuscular junction. It's important to know that it's a chronic autoimmune disorder. We have some autoimmune disorders that are what we call monophasic, that happen and then it goes away. The immune system self-corrects and it goes away. Myasthenia, on the other hand, or at least 8 to 9 times out of 10, doesn't correct on its own, and patients require treatment, so that's important to know. And the immune system is incredibly, incredibly complicated, and I've been trying for 25 years to understand it, and then I'm nowhere near understanding it. But one of the most important things, and I'm sure Mike talked about it this morning, is to know that there are antibodies or autoantibodies that attack the neuromuscular junction where nerve meets muscle, and that results in weakness. The immune system, like I said, it's really complex, and the way I try to conceptualize it, it has its own personality, and every individual has their own personality, and their immune system has its own unique personality. And it's a complex interaction of genetics and environment, of experience. That goes for your personality, and it goes for the immune system. And it is influenced by outside stimuli, just like your personality, your behavior is influenced by outside stimuli. Your own immune system is influenced by outside stimuli. So the immune system doesn't like bacteria, it doesn't like viruses, doesn't like cancers, doesn't like parasites, and it likes self. It wants to tolerate self, which seems very easy, but it's actually very, very complicated, and I don't understand how it possibly does it. It's not like these inflammatory cells have eyeballs and can identify what is self and what is a virus, but somehow it figures it all out. The immune system, like your personality, has good days and bad days, and it can be influenced by other things like drugs. Drugs can influence your personality, can influence the immune system. And to give this talk, we have to talk a little bit about the immune system, but I just throw up a few slides just to say that it's incredibly complicated. There are lots of different cells that play a role in the immune system. There are interactions between cells. There are adhesion molecules. There's all kinds of interactions, communications between different cells. And there are all kinds of things floating around like cytokines that make it even more complicated. But at a really fundamental level, it is what's important in myasthenia, and I'm sure Mike talked about this earlier, is that there is a loss of functioning acetylcholine receptors, or they're out of position or they're not functioning well in patients with myasthenia. The panel on the left shows a normal nerve-muscle junction, and you can see clusters of acetylcholine receptors right by the nerve. And the acetylcholine crosses the synapse, reaches the acetylcholine receptors, and then that leads to muscle contraction. On the right, you have a normal nerve, but you have an abnormal, what we call muscle end plate. There is less acetylcholine receptor, there's simplification of the end plate, and it's just a less effective, less efficient neuromuscular junction. And we'll talk about that more in a little bit. I think one thing that everyone should always keep in mind is your immune system's unique, you're unique, your myasthenia is unique, and when we see patients with myasthenia, we consider all the different aspects of that person. We think about their history, how long have they had it, how has it behaved up to that point. We think about current and past treatments, what's worked, what hasn't worked, what's been tolerated, what the side effects may or may not have been. We think about other medical history. If you have diabetes, then steroids may not be such a great choice because that can increase your blood sugar. I think it's very important to think about the patient's desires, what they want out of treatment. I think it's hard to determine risk and benefit if you don't know what benefit you're trying to achieve, what the patient wants you to achieve. We think about their quality of life, and we think about functional status, and we also characterize the myasthenia, and there are a number of ways to characterize one's myasthenia. We think about the distribution. Is it ocular only? Is it more generalized? Is it mild, moderate, severe? We think about the thymus history. Has the patient had a thymectomy, for example? Age of onset impacts us a little bit. There's early onset myasthenia and then later onset myasthenia, which is, we typically think of 40 as the cutoff for that. And then we think about the antibody status, which we call serology. And there have been major advances in our understanding of the antibodies in myasthenia in the last decade. So an antibody is a Y-shaped thing that we have probably millions circulating. I don't know what the number would be, but probably millions circulating in our body. And 99.999% are doing what they should be doing. They're looking for things like viruses and bacteria and doing what they should be doing. But then can be some, in autoimmune disease, there are rogue autoantibodies that are attacking something that it should not attack. And we're now up to 5 disease-causing, or probably disease-causing antibodies in myasthenia gravis. When I gave this talk last year, it was 4. Probably the year prior, it was 3, and the number has really grown. And it matters. The type of antibody influences what we call the phenotype, which is really the distribution and severity of the disease. And it also seems to influence the response to treatment, and that helps us, guides us when we're trying to decide what might be the best treatment. And there's some preliminary evidence that 2 antibodies, if a patient has 2 autoantibodies, myasthenia autoantibodies, it's probably worse than having 1. So the 5 are acetylcholine receptor, which you all have heard about, and that's been known for 40 years or so. Muscle-specific kinase, or MuSK, and yes? Yeah, I'm sorry. I can get one. Kathy, I'll get one. Yeah, absolutely. A handout? Sorry. Yeah, I noticed it. Not my fault. MuSK, muscle-specific kinase, another antibody. There's LRP4, which is the 3rd antibody, which was discovered 4 or 5 years ago. Agrin, which was identified about a year ago, and then Cortactin, that was reported on about 5 or 6 months ago. So it turns out that these structures that the immune system, the antibodies are attacking, are all at the neuromuscular junction, which makes good sense. And it turns out they all need each other. They're kind of a team. The acetylcholine receptor is the most important member of the team, because it receives the neurotransmitter that leads to then the muscle contraction. But the other ones, LRP, MuSK, Agrin, and Cortactin also play a role in keeping the acetylcholine receptors where they should be. So if there's any autoantibody attack to any of them, it can impact the neuromuscular junction and cause weakness. And you could think of the acetylcholine receptor as the quarterback, the Peyton Manning, the Tom Brady, the most important person on the team. But you need the other players on the team for the team to be successful. And as I showed earlier, the acetylcholine receptor antibodies are optimally positioned where you want them to be so they can receive the acetylcholine and then do their thing. And there are what we call clusters of acetylcholine receptors at the muscle end plate. We've known about that for about 40 years. If there were 100 patients in the room, probably about 85 would have antibodies to the acetylcholine receptor. If you had purely ocular myasthenia, it's probably around 50%, but if you do fancier lab testing, the numbers probably are a little bit higher than that. It's important to note that almost all animal research is done with the acetylcholine receptor model of disease, and the current clinical trials that I'll talk about have all been done with acetylcholine receptor positive myasthenia. MuSK was discovered about 12, 15 years ago. Turns out about 7% of patients with generalized MG have MuSK antibodies, and we know now that it helps cluster the acetylcholine. It helps position the acetylcholine receptor where it needs to be at the neuromuscular junction. Clinically, patients with MuSK MG tend to look a little bit different. They tend to have a little more facial weakness, a little more tongue, neck, or breathing weakness, and it tends to be a little bit more severe. It's not always the case, but there's a higher percentage of patients who require hospitalization at some point in their disease if they have MuSK MG compared to acetylcholine receptor. And importantly, it seems to respond better to certain treatments like plasma exchange and rituximab. It also responds to steroids, Cellcept, azathioprine, but plasma exchange and rituximab are probably the two best treatments for MuSK MG. And patients often don't. Some patients respond to Mestinon, or many don't with MuSK MG. And we're starting to realize that thymectomy if it has an effect, it's certainly a smaller effect than for acetylcholine receptor MG. This is a paper that came out a couple years ago from a group in Spain that demonstrated a long-lasting treatment effect in MuSK MG patients. Probably more so than the acetylcholine receptor. We'll talk about that in a bit. And my feeling is if I have a patient with MuSK MG, I try to get them rituximab. I think that's probably the right way to go. Not everybody practices that way, but I would do that a lot quicker than I would for a patient with acetylcholine receptor positive MG. There are differences. And Mike, who's in the back of the room, who gave the MG 101 talk today, is starting a study, multi-center study. It's a retrospective study where we're going to look at our experience in patients with MuSK MG, the treatment experience with rituximab. And there may be about a dozen centers, Mike, somewhere around there? More than that. Okay, good. So that'll take a year or two, but be on the lookout for that. The third antibody is LRP4, and it turns out that some myasthenic patients with LRP4 also have other antibodies like MuSK or acetylcholine receptor, and some don't. And it probably represents a few percent of patients. There are 2 or 3 patients maybe in the room who would have LRP antibodies. And it looks like if you had LRP alone, that was the only autoantibody you had, myasthenia autoantibody, you would tend to have a milder disease. But if you had that and something else, you would tend to have a more severe disease. And it turns out that LRP, like MuSK, is involved in the clustering or the positioning of the acetylcholine receptor at the optimal location at the neuromuscular junction. I want to mention that I mentioned this last year, but I want to mention it again. The recipient of the Clinician Scientist Award, MGFA AAN 3-year award, last year went to Ricardo Roda, who's at the NIH, and he is doing a study on the clinical significance and pathogenic mechanisms of LRP antibodies in myasthenia gravis. So he's studying LRP antibodies in myasthenia gravis. The fourth autoantibody is agrin, and we've known about this maybe a year or so. And just like LRP and MuSK, it's involved in clustering of the acetylcholine receptor antibodies. So it's another member of the team at the muscle end plate side of the neuromuscular junction. And with agrin, patients with agrin antibodies, most also have acetylcholine receptor antibody or MuSK antibody. And so again, it may be that if you have that and MuSK or that and acetylcholine receptor antibodies, you might have more severe disease. That needs to be worked out, again, involved with the clustering. And the fifth, this came out 5-6 months ago. It is Cortactin. And so there was a study in Barcelona in the Netherlands that identified this fifth autoantibody called Cortactin. It needs to be further worked out, but it seems to be overrepresented in patients with myasthenia, and it's also involved in the clustering of acetylcholine receptors, and so it probably plays a role, and it's more work needs to be done, but it is an interesting fifth antibody, again involved probably in the clustering and functioning of the acetylcholine receptor. Okay, so why do we care about antibodies? What has diagnostic value? If you start tallying up what percent of patients have these antibodies, for generalized MG, you get to suddenly around 98%. So it's a blood test. So that has diagnostic value right off the bat. And as I've said, it helps us characterize the patient's myasthenia better. We think MuSK tends to be a little bit more severe. We know that the thymus is a player if you have acetylcholine receptor MG, and maybe less important if you have MuSK MG. And we are starting to think 2 autoantibodies would be worse than 1. Just knowing that there are probably 5 autoantibodies helps us understand the immunology of myasthenia better, because different things happen depending on which antibody you have. And it gives us a better roadmap for treatment. Rituximab, like I mentioned earlier, or plasma exchange, I think are very good choices for MuSK MG, and I would tend to stay away from thymectomy in a patient with MuSK MG. So it influences, I think, our treatment to some extent. Right now, I'm aware of only the acetylcholine receptor and the MuSK autoantibodies being commercially available. So if you got your blood test, I believe it's only those 2. I don't think LRP is yet commercially available. Is anybody aware of LRP being commercially available? So the LRP, agrin, and Cortactin are available in certain labs, but not yet commercially available, and that'll change at some point, but I'm not sure when. Okay, so that's what I have on autoantibodies, and now I want to talk about 4 clinical trials, and then I'll talk about promising developments that I think are very exciting, and then a few other things. So, you know, the 4 reasons I think we treat our patients with myasthenia is 1, to keep them alive, 2, keep patients out of the hospital. You know, keep them, you don't want them to have an exacerbation of their myasthenia and end up in the hospital. That's not ideal. We obviously want to keep everybody functioning, and we want to keep everybody happy, and we're trying to do that by finding the right drugs and minimizing the side effects, minimizing the risk of those drugs. And another way I think of this, and I showed this slide last year, I'm from the University of Virginia, where Thomas Jefferson's from, and he was the main writer of the Declaration of Independence. But what we do, and I think in myasthenia, is we try to preserve life, liberty, and the pursuit of happiness. We try to keep our patients alive. And what I mean by liberty is we try to preserve the freedom from symptoms, the freedom from side effects, and the freedom to function, the freedom to do what everybody wants to do when they want to do it, not only in the morning, but in the afternoon or the evening. So we try to give patients freedom. And then the pursuit of happiness, and what I mean by that is quality of life. So I think I like that idea. That's what we're trying to do when we treat patients. And Mike talked this morning about different treatments, I'm sure, and I'm not going to talk about standard treatments, but we have quite a few. You know, we have prednisone and azathioprine and mycophenolate and pyridostigmine and IVIG, plasma exchange, and thymectomy, and so we have lots of treatment options. And we're always, trying to figure out what's best for an individual and then at what dose, and it's challenging. So let's talk about 4 ongoing or just completed clinical trials. And one is eculizumab, and the Alexion folks are here, and they have a table outside of the room. They've got a neat compound called eculizumab, and it inhibits something called complement. So when there's antibody attack, it can result in a cascade of events that includes the production of proteins called complement. And complement can be damaging. Complement can be a very good thing. It can go after bacteria and things like that and kill bacteria, but in somebody with myasthenia gravis who's acetylcholine receptor positive, it can do damage to the muscle end plate, do damage to the neuromuscular junction. And so complement can be a bad thing. And eculizumab is a drug that shuts down or reduces the amount of complement, and the hope is that it works in myasthenia gravis. And there is now a phase 3 trial, an international trial. Patients are randomized to either the drug or placebo. It's international. There are, I think, over 100 centers around the world involved in the trial. And the primary endpoint is going to be a change from baseline in a patient-reported scale, function scale called Activities of Daily Living. And it's a well-designed, yes. Yep. Yes, it's right here. Thank you. It's, and there's a great brochure outside the room that has good detail. Yes? Oh, the question was who could qualify? Yeah, and I know there's a panel discussion, I think it's tomorrow also on clinical trials, but there's a good brochure outside of the room too. But the answer, though, is that it's patients who have adults with generalized myasthenia gravis who have acetylcholine receptor antibodies, not MuSK, but acetylcholine receptor, who have moderate myasthenia, mild to moderate, and who have failed at least, failed approximately 2 other drugs. It can be one drug, and then they could require IVIG, but they can't be doing great on monotherapy. That would not be the right person you would put in this trial, of course. And there are exclusion criteria. If you've had a thymoma or a recent thymectomy, then that's an exclusion criteria. If you need IVIG frequently or plasma exchange frequently and you've had it in the last 4 weeks, that would be an exclusion criteria. And pregnant and breastfeeding is an exclusion criteria. And so I think it's a very well-designed trial. Patients will be randomized, again, 1-to-1. Randomized means you either get the drug or you get the placebo, to get either the eculizumab for 26 weeks or to get the placebo for 26 weeks. And if you're in the placebo group and you're not doing well, obviously, ethically, the doctor can provide other rescue treatments. I mean, patients are on treatment, but you could add in IVIG or plasma exchange as needed. If the patient needs that during the 26 weeks of the trial. And then after the 26 weeks, there's an open label extension where everybody would get the drug. Everybody would get the eculizumab. Okay. The next trial that I want to mention is rituximab. And rituximab removes, it's what we call monoclonal antibody. It removes antibody-producing B cells. B cells are lymphocytes that make these antibodies that I've been talking about, and rituximab can remove subsets of them. And that rituximab itself has been around for 10, 15 years, first in lymphoma, and is being used in many other now autoimmune disease. And as I said earlier, it seems to work really well with MuSK-MG, we think. And it also seems to work in acetylcholine receptor MG, and I've certainly prescribed it, but we're not 100% sure. We think it works, but we're not 100% sure. And so there's an NIH trial that, again, is randomized, blinded, multi-center trial, and the 2 questions are, 1, is it safe? And 2, does it allow lowering of the prednisone dose? So these are patients who need to be on prednisone. I have a slide in a second. It's a 1-year trial. Patients get 4 weeks of the rituximab, and then half a year, roughly, well, 24 weeks later, they get another 4 weeks of it. And key inclusion criteria, again, acetylcholine receptor positive, generalized MG. Patients must be on prednisone of 15 milligrams daily or more. You can be on another drug like Imuran or Cellcept. And like their eculizumab trial, no history of thymoma. That's part of the inclusion or exclusion criteria, however you want to look at it. You can't be dependent on IVIG or plasma exchange. Again, you can't be pregnant or breastfeeding or without contraception. And so far, they're doing well in terms of their recruitment. They seem to be doing pretty well, and it's an exciting trial also. And there's information on the website, the myasthenia.org website, and I think an email blast went out the other day that has more detail on these two trials, the eculizumab trial and the rituximab trial. Now, we just completed a methotrexate trial and announced the results within the last year. So methotrexate has been around for 40, 50 years. Mostly used in rheumatoid arthritis, and it seems to calm down T cells and B cells. And it's been used off-label a little bit in myasthenia, but we did a larger study to answer two questions. Can we lower the steroid dose in patients who get methotrexate? And also the second question is there myasthenia better? And I guess a third question is it safe? We know a lot about methotrexate from decades of use and other disorders, but that's obviously an important question. So patients in this trial, pretty similar to the rituximab in that they had to be generalized acetylcholine receptor positive myasthenia on at least 10 milligrams of prednisone. But these patients can't be on other immunosuppressants. This trial is completed, but this is the cohort that was looked at. This is the population that was looked at. And it was a 12-month trial, and the results were mixed. It was well tolerated, which is good, but our primary outcome was were we able to lower the prednisone dose enough in patients who got methotrexate relative to patients who got placebo as an indicator of benefit from the methotrexate. And there are a lot of numbers, but if you take the mean daily dose of prednisone, it was higher for the placebo group, but not that much higher, 12.8 versus 14.8. So the methotrexate group had a mean daily prednisone dose at the end of the trial of 12.8. In the placebo group, it was 14.8. So it was a negative trial. But the patients who got methotrexate seemed to have better disease scores. Not all of them, but some of them. The MG composite improved in the methotrexate group by 4.8 points, which is pretty significant, versus 2.5 points for the placebo group. And the activities of daily living score was also better for the methotrexate group. Also, 3 of 25 in the placebo group withdrew from the study because of worsening MG, and 0 of 25 in the methotrexate dropped out due to worsening. So what does this mean? Well, first it means studies are difficult to design and very difficult to carry out. And I was part of the steering committee that set up this trial, and it's not easy. You know, first and foremost, you have to design a trial that doesn't put your patients who get placebo, doesn't put them at risk. That's unethical, that's bad medicine, and we don't do it. You need a placebo group, we think, so that we can look for differences, but you can't put the placebo group at risk, and that's why the prednisone dose turned out to be what we used, because that seemed like something we could measure without putting patients at risk. There are always questions about the duration of the trial. Should it be 12 months? Should it be 18? Should it be 6? Does it put patients at unnecessary risk if the trial's too long and they happen to be in the placebo group? And you've got to think a little bit about cost. And then there's always a discussion about what should be the primary outcome. What are we measuring? What is our indicator of benefit? And then, you know, myasthenia is a pretty heterogeneous disease, but you have to focus in on a subset of patients. And so you need to find that balance, and it's not easy. So anyway, my best guess is, and this may be wrong, but my best guess is methotrexate probably works, but it didn't strike me as extremely potent. So I consider it an option. I wouldn't start with it. I don't know where to put it in the order of treatments, but personally I wouldn't start with it, but it probably does help to some extent. Okay, and then thymectomy, just a quick update. So the thymus gland is involved in teaching right from wrong for the immune system, teaching the immune system what it should tolerate, what it shouldn't tolerate, and it does it very early in life. And in patients with acetylcholine receptor positive MG, there turns out that there tends to be more inflammation, more of a thymus than there should be. It usually atrophies in the first decade of life, and in many patients with acetylcholine receptor positive MG, that doesn't happen. So since the late 1930s, thymectomies have been performed on many patients with myasthenia, but there's not yet a prospective randomized controlled trial, a gold standard trial. And you all have probably heard about this trial. This trial's been around for a while, the MGTX thymectomy trial. And the question is, does the transsternal, not the video-assisted robotic, but the transsternal thymectomy combined with prednisone result in a greater improvement in weakness, a lower total score of prednisone, similar to the methotrexate, but this time over 3 years and not 1 year, and an enhanced quality of life? Those are the questions. There's also studies that will look at certain biomarkers, that will look at the thymus. There's a lot of other studies, results that will come out of this trial. It's an important trial. It has been in the works for 15 years. It took 5-6 years to get it going, which sounds like a long time, but it's a pretty remarkable trial, and it's an international trial, and they had to organize, prepare, they had to come up with a good protocol, they had to get grant funding, and the MGFA supported it, and then there's always the bureaucracy that we deal with when we're doing any kind of research. First patient was enrolled in 2006. The 126th patient was enrolled in November 2012, and it is a 3-year trial. So that last patient will have completed the 3 years in November 2015. So this winter, fall, winter. And the plan, as I understand it, is that there will be some results released in January 2016. So in 8 months from now. And then over the coming years, there'll be additional results released. Gil Wolfe, Henry, Gary Cutter, and many others are very involved, and there will be a lot of important results that will come from that trial. Okay, so that's the existing or just completed trials. Eculizumab, again, it works at this complement system. Rituximab, that goes after B cells that can make bad autoantibodies that can cause myasthenia. Methotrexate affects B and T cells, which are both cells involved in the immune system, and then the thymectomy trial. And there is a 5th trial, belimumab, which is a trial that GSK is doing, and I don't have any updates on that right now, so I didn't include that. Okay, now let's spend a few minutes talking about promising developments. And the 5 things I want to cover are vaccine and myasthenia, genetic predisposition, a little bit more on complement inhibition. Yes, question?
I just want to go back just a second regarding the clinical trials.
Yeah.
How many people were involved in those clinical trials?
How many patients? So the eculizumab, I think it's around 100. It's going to be around 100. Is that right? 92 total? Okay, so that's going to be 92. The rituximab is going to be 50. The methotrexate was 50, and the thymectomy was 126. Okay, you're welcome. Straight through here. Yeah. Pardon? Yep, split down the middle. Yep. Okay, so I'll talk about vaccines, genetic predisposition, a little bit more in complement. This FcRn, I'll get into just very briefly, and then B-cell activating factor. So this is pretty neat stuff. I mean, we normally think of vaccines as provoking the immune system. You get a flu shot so that your immune system's on high alert for when the flu comes, and then you fight it off. And so you have a hyperactive, hyper-alert immune system for something that may be coming. Two guys out of Penn, Jon Lindstrom, who's a very big name in myasthenia and has been a long time, and Ji Lu, who I'd not met, published a paper in the Journal of Immunology within the last half year where they gave rats with EAMG, which is an experimental allergic myasthenia gravis. They gave the rats a vaccine to the cytoplasmic, and I'll show you a picture in a second, acetylcholine receptor proteins, and they reversed the weakness in the rats. And they were able to do it in early EAMG, so they gave the rats the myasthenia and then quickly gave the vaccine, and the rats got better. And they also did it in rats who had, they called chronic EAMG, had myasthenia for a while, and showed that it also led to significant improvement in strength. Okay, so this is the acetylcholine receptor, and Mike may have shown a picture of it earlier today, but there's the outside part and then the inside part, and the inside part is what we call the cytoplasmic part within the cell, and they gave the vaccine to the lower part, the cytoplasmic domain, and somehow that improved the rats' myasthenia. And they speculate in the paper on why it might work. Maybe there's early death to these plasma cells that make antibodies. Perhaps there's downregulation of helper T cells, and it might also shift the subtypes of immunoglobulin and affect the complement. And they had some evidence to back up some of this speculation. I don't claim to understand it any better than that. There is an interview on the MGFA website, myasthenia.org, interview of Jon Lindstrom, and it's worth looking at, and I just cut and pasted 3 quotes, and I'll just read them. He says, "What needs to be done before testing on human MG is to determine the best human compatible adjuvant," and that's just the solution for the vaccine, simply put. "And then we would like to test it on naturally occurring MG in cats." Cats. Yeah, I guess, yes, question. I don't know. So the question is, why cats rather than another animal? I certainly don't know. Anybody in here know? They got 9 lives, is that what I was supposed to say? I don't have any idea. I don't know. He went on to say, "We see this as a curative vaccine, hopefully in the future, that would suppress ongoing MG and prevent its recurrence. We are anxious to see the vaccine available as soon as possible, but this may take several years. This will depend on getting support for further research, first in animals and then in humans, and on having the experiments work out as we think they will." So it's very exciting, great promise. A few more years of work to do. All right, let me say something about genetic predisposition in MG. And just the genetics of myasthenia gravis. Myasthenia gravis isn't what we would call an inherited disorder. It's unlikely that you would pass it on to your children. There are a few exceptions, but very few exceptions. But like everything, we have genetic predispositions. We have increased and decreased risks on a genetic basis. But it's important to study the genetics of myasthenia. It helps us better understand the immunology, and it allows us to think about new targets of intervention, targets of treatment. And the MGFA supported this research, and Sam mentioned it this morning, but a genome-wide association study where they looked at the genome of patients with myasthenia and compared them to patients who didn't have, or people who didn't have myasthenia, and they were able to find a few DNA changes in a few genes that were more common in MG compared to the controls, the patients without MG. And, you know, they're letters and numbers, and when you just first look at it, it's hard to get terribly excited about, but I'll explain in a minute why it is exciting. The patients, MG patients, let's just use CTLA4 at certain DNA locations, 0.45% had that, what we call variant or polymorphism, versus 0.38 in the control. So a difference of 0.08 frequency. Not hugely exciting. And then the same went for the HLA and the TNF-RS11A. So I'll explain in a second why it matters, but the one thing to say right now is don't run off and try to get DNA testing. I don't think that would do any good for anybody anybody with a myasthenia gravis. So who cares? Well, we do care, because if this, and we'll use CTLA4 as an example, if the CTLA4, if there's a genetic predisposition with this behavior of the CTLA4 molecule, then maybe trying to tweak that would improve somebody's myasthenia gravis. That is probably a clue. The immunology or the immunopathology is incredibly complex, but that's probably a clue of one of the little players in myasthenia gravis. And it turns out there are 2 drugs already available that are used for rheumatoid arthritis that are also trying to tweak this CTLA4 system. Don't run off and get these rheumatoid arthritis drugs. I mean, this is just an illustration of, you know, this gives us a little foothold, a little clue that will lead to further investigation. So it is worthwhile doing these what we call GWAS, genome-wide association studies. And again, by understanding the genetic predispositions of the personality of the immune system, such as the CTLA4 signaling, we learn about what influences myasthenia, and by learning about what influences myasthenia, we may have some future treatment options. Okay. Complement inhibition, I mentioned eculizumab earlier in the ongoing trial. And there are others who are looking at complement, and this is coming out of Linda Kusner and Henry Kaminsky, and a biotech company have tried by using siRNA, which is just by silencing the expression of complement in a rat model, they've been able to show improvement in strength. This is to keep it short and simple. Sorry, good question. What is C5? C5 is one of the proteins, one of the components of complement. Yeah, and eculizumab also goes after C5. It's just a critical part of this complement cascade that can do damage at the neuromuscular junction. So people are looking at other parts of the complement system and trying to improve myasthenia. Okay, so to summarize that, therapies are being developed to inhibit the complement cascade in myasthenia. I just mentioned this siRNA. Earlier mentioned eculizumab, and then there was some work last year that I presented on this DK accelerating factor and complement. I'm not sure where that is now, but there are people looking at it. And complement is particularly important in acetylcholine receptor, MG, maybe LRP4, and probably less important in MuSK-MG, getting back to this idea that it really does matter to characterize a patient's MG, better understand it. Okay, FcRn therapies, this may turn out to be a big thing. There's certainly a lot of interest all of a sudden in this, and FcRn is basically it protects antibodies from being degraded. We all have it in us, and it keeps the antibodies around longer than they otherwise would be. They would be chewed up, degraded earlier if we didn't have this FcRn. And so if you inhibit the protector, maybe we do chew up these bad antibodies that cause myasthenia. So maybe, and there are compounds that inhibit this protector called FcRn. And in rats with myasthenia, rats who were given this FcRn inhibitor, there was improvement again in the myasthenia, and the acetylcholine receptors levels dropped, which is what you would expect because it's chewing up, catabolizing the acetylcholine receptor antibodies quicker. So very promising. A lot of interest in this right now. And I think over the next few years, the hope would be there will be some clinical trials there. Last thing I'll say is B-cell activating factor, IL-10 stuff, and I wanted to mention this because Jeff Guptill, who was the last recipient of the AAN MGFA 3-year fellowship, which was a huge success, has done a lot of important work with MuSK-MG, and he's shown a number of things. He had a paper out in our top journal, Neurology, about a month ago, and he showed 3 things, and he's done other work and other publications from this fellowship. But one, that the antibody levels seem to correlate with disease severity. That's worth knowing. And that there are cells called B10 cells that produce this cytokine called IL-10 that can inhibit or calm down T and B cells, and that would be a good thing in somebody with myasthenia. And BAFF, which is B-cell activating factor levels, are also abnormal in patients with myasthenia. Again, just kind of teasing out what's going on with the immunology of myasthenia, and in this particular case, we're talking MuSK-MG. Okay, just real quickly, a few other things. So there's a lot happening in myasthenia, and I think in the future there will be many more treatments, and they should be more potent and hopefully safer treatments. But with the coming of new treatments will be the rising cost of treatment, I think. And we consider cost now when we make our decisions. It's certainly not the top consideration, but the truth is we have to think a little bit about costs when we prescribe. Again, not a major player, but something we consider. And these new treatments, especially for rare diseases, are turning out to be very expensive. And the payers who are paying for these treatments are coming up with more and more reasons not to pay for it. Sometimes it's a technicality. And an example is we just published an editorial because we've been using mycophenolate a lot at UVA, and we have plenty of patients who are on it and only it. I'm not saying it's for everybody because it's definitely not, but we have some patients who do really well on it who've been on it for years. And then January 2015, we start getting all these letters from the insurance companies saying they weren't going to pay for it. And it was a new development, so we raised hell and wrote an editorial. And I think we may have won that battle, but there are going to be more battles. And I think it's important that the MGFA has a voice. And I think the discussions are going to get louder and louder, and the MGFA needs to have a loud voice. And it needs to be a voice of reason. We obviously need these new drugs. We need investment. It's not cheap to put on a clinical trial. There needs to be return on investment. But we need to be part of the discussion. And there's going to be an advocacy group of the MGFA that we were talking about yesterday at the board meeting. But I just want to put that on the radar. Now, last 2 things. You've heard about the registry before. Been doing it for 2 years now. We collect a lot of information, but we think it's important information. We have somewhere around 900, maybe 1,000 people who have signed up. The reasons for the registry, one, to centralize a database of patients, and importantly, to help scientists, clinicians learn more about myasthenia, especially what are the unmet needs of the myasthenia community around the country. And that can also help pharma and biotech learn about what the unmet needs are. So we think it's an important endeavor. We have about, like I said, maybe 1,000 patients, somewhere right around there, but that's only somewhere around 2 to 3% of the U.S. myasthenia population, and that's not enough. That's just not enough to have meaningful results. It's a big number, but it's only a small subset of patients with myasthenia, and so we're not sure about the validity of that information right now. And so we're talking about ways to increase. We need to increase recruitment, and we're talking about shifting some of the questions to Survey 2 or Survey 3, so it's not so top-heavy, so onerous with Survey 1, and also other ways to make it of a benefit, immediate benefit to the patient. And so there are ongoing discussions about that. If you haven't signed up, please consider doing it. If you know others who haven't signed up, please consider that. The app, we created that in 2012. We had a big upgrade in 2014, and there's going to be another big upgrade coming in 2015. Right now, it has really 4 components: drugs to avoid, which I think is important, very important, probably the most important thing. We have information, a statement on vaccines. We have podcasts, educational podcasts. You just tap on it, and you can listen to a podcast. And then we have patient surveys. And the 5th thing that will be coming, hopefully soon, is news, that there will be news disseminated from the MGFA onto the app. Maybe there's a research breakthrough, or there's a walk in Orlando in 3 weeks, news. So this is what it looks like now. Some of you have it, some of you I'm sure don't, but we have information on drugs to be cautious about, drugs to avoid if you can, comments on vaccines. And I think this is very important, and this is and I showed this last year. The woman is my research coordinator, and she's acting like she's a patient who's pulled out her phone, and the guy on the left was a med student. And so they're obviously just role-playing here. But she says, it says here that the drug might not be a good choice in myasthenia. Say you're in the emergency room, you got bronchitis or something, and they want to throw you on something. You say, well, I have myasthenia, and they've never heard it. Well, they've probably heard of myasthenia, but they don't know that much about it. And they just want to throw you on their favorite antibiotic. You need to pull up that app and say, I don't know, or at least look at this and tell me if this is a good choice or not. Because you would be maybe not surprised. I mean, there's just no way primary care doctors can know everything about everything, including what drugs we need to be cautious about in myasthenia. Podcasts are available, surveys are available, and please check it out, and it will get a major upgrade soon. The end. Questions? Yes?
Any research about hemp seed oil?
I'm not. Hep seed oil?
Hemp seed oil.
Hemp seed oil.
No, it's not marijuana.
Not marijuana.
Hemp seed oil.
Hemp seed. Hemp.
I don't know of any. Does anyone in the room know of any research on that? I don't. I don't know.
All right. There are folks who have been successful with it, that's all.
Okay. Okay. I'll have to read about it.
Seizures. It's for seizures.
Okay.
Seizure.
All right. I'll read about it.
Yes, a real quick question. The app, is it going to be automatically updated? I don't have it yet, and I'd like to download it, but if you're going to upgrade,
Well,
is it going to be like automatic?
no, that's a good question. Yeah, you download it once, and then the information would be added to it. You wouldn't need to keep up. You wouldn't keep downloading it.
iPhone notifies you if there's an update. So whoever your developer is will probably roll out the update.
Yeah. Yeah.
There's a notice on the iPhone app. I'm not sure about the other phones.
I don't fully understand a lot of the technicalities, but I don't think you'll have to download an updated upgrade. I think it'll just get better. If you have it, it'll get better. Yes.
I have 2 little comments. Your talk was excellent. Thank you so much. But the doctor I work with is having the older kids on the MyMG app save all their data, including their hospitalizations and how long they're in the hospital. And then she even has them write down the total cost of their hospitalizations from, by their insurance company and how much they had to pay. And the reason is she's submitting this to the insurance companies when they deny the future use of IVIG. And we've gotten two approvals already based on that app, MyMG, based on those kids. And now I see this guy to my left. How old are you, Victor?
16.
He's 16. He's a little shy. But I know he can use an app really well. And I have 12-year-old kids that are on this, these smartphones. So we're going to start lowering our age to the people that we ask to use that app. And that's going to get us the approval from the insurance companies. They don't care what we say about our research articles. They don't care. They just care that it's keeping their patient out of the hospital and costing them 40, 60, grand. The other thing is when a little boy went into the emergency room and they gave him azithromycin, okay? Gave him a Z-Pack. Oops. And the mother brought the medicine in, which was a good mother, to show us everything that the little boy was taking. And we went, ruh-roh, you know, that's not good. We don't know why, like they know if a man has Viagra, if a man comes into an ER and he's taking Viagra, everybody knows there are these certain drips that you don't give the guy. You know what I mean? Everybody knows it.
Right.
And what I'm wondering is, why don't we, at least in our own ERs, I think our ER is okay, but I don't know about everybody's, tell them, just Google MCFA and pick out drugs not to give to people with myasthenia gravis.
Yeah.
Or better yet, some of our moms, especially the Spanish speaking, we Xerox, you know, we copy that list of meds, say put it in your wallet, and they take it to every ER they go and they show it to the doctors.
Yeah.
And the doctors don't screw up anymore.
Right.
Or whoever, you know, PAs, nurse practitioners, everybody. So I'm just saying, it's a small thing, but it really has saved some of our kids some bad stuff.
Yeah, no, it's important. It is a small thing, but it's actually a big thing. Yeah, it's very important. And however you do it, if you've got a sheet of paper that you keep in your wallet, that's fine too. Most people keep a cell phone on them. Not everybody's got a smartphone, but they will at some point, and I think it's a pretty good way. I will say that the list that we came up with is not an exhaustive list. It's not like a 4-page list of drugs. We picked the ones that we thought were the most concerning, because if you have too many drugs, then suddenly the doctor's somewhat paralyzed because they see all these drugs and they can't think of what they can prescribe. So rightly or wrongly, we made it a fairly short list.
I'm wondering if you could talk a little bit about high-dose cyclophosphamide with stem cell rescue and what the trials are
you know,
showing
I
that?
can. I've never done that. I know the Hopkins group, in particular, Drockman. Okay, the question was high-dose cyclophosphamide with stem cell rescue. I know it's been published. I've never done it, rightly or wrongly. It's very aggressive, very intense, dangerous, but some people need it. I've not needed to do that, and I'm certainly no expert in it.